1, yay. Okay, so tonight we're going to have some fun. We're going to talk about people with problems. And based on the statistics, there's probably some people amongst us right now with these problems. Okay, so what I'm presenting tonight, I literally cover in a class in the spring over 3 weeks. Okay, so this is really a bird's eye view of several hallmark psychiatric conditions. Okay? So if it seems quick, it is. And if you're interested in learning more, enroll in neurobiology disease. So for each one, I'm basically going over some basic pharmacology about the disorder, some of the neuroanatomy about the disorder, what causes it, and whether some people are more or less vulnerable. Okay? And that's going to be the outline for each of those 5 conditions: addiction, anxiety, major depression, bipolar, and schizophrenia. Sort of the big 5, if you will. All right, so let's start with addiction. So I'm going to present addiction in the context of drug addiction, because that's what we typically think of. But I believe that addiction is addiction. All right? So a lot of the same underlying mechanisms for drug addiction are likely involved in gambling addiction, sexual addiction. I think some people get addicted to exercising. Any kind of addiction, there's some fundamental circuits there. It's not just all about drugs and alcohol. That said, here are some statistics about drugs and alcohol. All right? Just to give you an idea of the scope of the problem, and I know we hear about this seemingly on a daily basis these days. But you are talking about millions and millions and millions of people that have an addiction to any one of these substances, in many cases more than one of these substances. Okay? And this one on top is probably going to keep growing as it becomes more and more legal, and it's going to end up matching alcohol eventually. So what kind of, that looks fuzzy to me. So what kind of drugs are being abused? And they basically fall into a few general categories. And then this is broken up by the age ranges. So you can see what age range humans are more or less addicted to this type of drug. So you can see that things like pain relievers, right, and we've heard about the opioid epidemic for years now, is largely a disorder of older adults, okay, because it's older adults who wind up getting put on these prescriptions because of various pain conditions, right? When you start looking at things like stimulants, now you're talking a generally much younger population, right? And then the sedatives, which would include things like alcohol, again, older, tranquilizers, again, younger, right? This is important because when we're thinking about understanding these processes, if you tend to see it in one age over another, you might be talking about either a vulnerability or even a possible different circuitry that may need to kind of maturate over time. Now, this is the history of addiction on one slide. And I like to, do these little mini history lessons because I think it's important to understand the context of these things. So, addiction did not exist as a term until you get to almost 1900, right? Before that, they were just inebriates, okay? And what did you do with inebriates? You locked them up until they dried out, and then you let them go on their merry way, okay? That's what they did for hundreds of years, because it's, things like alcohol have been around forever. And it wasn't really until you get to the 1800s when people start really looking at it as not just simply bad behavior, as something that maybe you need to cure people of this bad behavior. So it was around the time of the Reformation that you see this idea of curing people of this inebriate behavior come into the literature, right? And then later on, by the end of that century, you actually see the term addiction. And where you really see it a lot is following the United States Civil War, because that's when there was a sort of like that first epidemic, if you will, of drug addiction. Anybody want to take a guess at what it was? It was one particular drug at that time that was just developed to relieve pain.
Was it morphine?
Morphine. Okay? That was developed and used heavily during the Civil War because of a lot of amputations. Right? So that's when you really had that first, if you will, opioid epidemic, was in the 1860s and 1870s. Now, by the time you get to the 1950s, now you have organizations like the World Health Organization and the AMA recognizing alcoholism in particular as a disease, right? This is where you see the disease model come about that has since really been a very dominant approach to addiction, right? And in fact, a few years later, Jellinek publishes the famous book, The Disease Concept of Alcoholism, right? And this is the foundation of things like AA, right? And the idea that a person has little control over this, that it's a disease, and they have to approach it as such. Now, I will say, in contrast to this, there's always been this countercurrent from the non-medical profession, from clinical psychology, that has been addiction is a learned behavior. And as a learned behavior, it can be extinguished. So you really have these very dichotomous views of how you would go about dealing with somebody with an addiction. Where, one is saying, look, you have no control over this. You just have to do everything possible to not allow this disease to take over. And another one saying, no, you actually have control over your actions. You just need to learn how to do it. Right? So depending on what kind of therapy you went in, you get two very different approaches. So come the 1990s, you have the American Psychiatric Association publishes in their DSM-4 actually alcoholism as a disease. Now that's the Psychiatric Association. Those are the, the MDs, not the psychologists, not the PhDs. All right. The hedonic or opponent process theory of addiction is really one of the founding models of what is occurring in the body and brain when an individual becomes addicted to a substance. And it's an old theory, but people still harken back to this today because of its basic principles, and this is why I still teach it today. And it's a pretty simple model and captures a lot of what we think happens pharmacologically, physiologically, in the brain and body. So what you have here that Solomon proposed, and Solomon was one of those learning people, not medical model people, was that you experience two states when you ingest any type of substance. That first state is the active state of the drug, what the drug is known to do. And that's shown up here, the experienced state, this first row. And the A state is what the drug does. And so you can see on this generic scale of A to B, A is whatever that effect of the drug is. Okay? Could be stimulant, could be, sedative, whatever. And what he said is you have this acute effect and it kind of dissipates over time, and then what you typically have then is a B state, which is the exact opposite of the A state. So if your drug's a stimulant, it's more of a depressive-like effect. Okay? Now, early in the drug addiction process, he said you experience this A state strongly, and you experience some level of B state, albeit not to the same degree. But after addiction, what happens is that A state gets smaller and smaller and smaller in magnitude. That same amount of drug has less and less of an effect. What do we call that? Tolerance, right? Right. Now, what he also said was, as that gets smaller, the B state gets larger. And that B state could be thought of as withdrawal, right? Because it's the exact opposite. Now, pretty simple, right? Now, what's interesting is how what he proposed was occurring that leads to this. And that's what's shown down here in the second row. What he said was physiologically what's happening that's causing these two states to occur and then change over time. So these are the processes. And again, it's on a scale of A to B. And the A process is the actual physiological / pharmacological effect of the substance. Right? So here's the A process. So there's the drug. See down here. It gets ingested. It quickly has an effect. And then over time, it dissipates. Now, what he said was that once this A process starts, not soon, too long afterwards, your body reacts. And your body's going to react in the opposite direction because that's what it does, right? the body always wants to be at what? Homeostasis. So then he said there's a B process, which is that homeostatic mechanism. Try to bring it back. You take a psychostimulant to get yourself all jacked up. Your body is doing everything possible to counteract it. That's the B process. With repeated ingestion, notice that that A process, he said, doesn't change. The drug's the drug. What's changing that causes this A state to shrink is that B process, getting stronger and stronger and stronger. And notice too, see how there's a little bit of a delay here in that initial part? Notice almost no delay either. So it's stronger and faster to oppose that A process. And so he said if you take these two processes and basically do a subtraction, you get a much smaller A state and a much stronger B state. And so that's how he tried to explain the process of addiction, at least as it relates to things like tolerance and withdrawal. Pretty simple model, but it captures much of the features that we see in addiction. And obviously the model is actually pretty old at this point. Any questions about this? Whoops. No? Okay. Now remember that this model of opponent process is really about hedonics. And so the whole history of addiction research in neuroscience for the longest time was about hedonics. The idea that individuals are chasing that feeling good sensation. And it's whatever your drug of choice is that makes you feel that, nice hedonic, positive feeling. So for the longest time, the model for addiction was, in animals, how much is an animal willing to work to get that presumed hedonic feeling from a drug? The more they're willing to work, the more addictive we presumed a drug was. Everybody follow? Right? So these are just some examples of some typical data that you would see. So for instance, here at the top you have cocaine and an animal pressing, over 100 times to get a single dose. Right? So what you typically do in these types of studies is that you initially teach them, you hit the bar and you get a dose of whatever drug. Once they get that down pat, which usually doesn't take too long, then you say, okay, now you have to hit it 2 times. Now you have to hit it 4 times. Now you have to hit it 8 times. You just ramp it up, what we call a progressive ratio schedule. And so you can get it up to hundreds of times for a single dose. Right? So that's where, and then we can actually look at things like break point, which is when will they not work anymore? And so we look at differences in break point to determine the, if you will, the addictive properties of a drug. So, like I said, here's cocaine, here's heroin, here's methamphetamine. This one's around 75. Like I said, that one's around 100. That one is topping out around 200. Right? So based on that data, we would say, well, clearly, at least with the doses you're using here, the methamphetamine would be more addictive. Now, the other way that this can be done is kind of doing the flip, which is we teach them the work for it, but we give them less drug for that response. So say we work them up to, okay, the animal's pressing 50 times to get a single dose. Then we start backing off on the dose. And then saying, okay, how many times are they willing to work that 50 times to keep it going? So you kind of see the inverse, but it's the same idea. Take away the drug, but how much are they willing to work to keep it going? Any questions? Right. So this is very traditional way that people studied addiction for decades. I mean, this starts back in the 50s. And how we study and how we kind of think about what is occurring physiologically is largely going to be based on how we are studying it. What do I mean? Well, if our model is based on hedonics and positive reinforcement, then the way we go about saying the brain circuitry underlying addiction is going to be about positive reinforcement and hedonics. And that's going to be important in another slide or two. So if you looked at any textbook up until literally the early 2000s, you would see this particular pathway here as being the addiction circuit. And that pathway is a dopamine pathway between the ventral tegmental area and the nucleus accumbens. Just see. It's all about dopamine. So this is just a blow up of that circuit. And so you have the VTA dopamine neuron here. It projects all the way to the nucleus accumbens in the ventral striatum. It releases dopamine. And what did we learn about that circuit? Oh, it just so happens what receptors are there. Well, of course there's dopamine receptors there. Are there any drugs that seem to affect dopamine transmission that might be related to addiction? Amphetamine, methamphetamine, cocaine. All three of those drugs have a common property. They facilitate the release of dopamine. The major difference is that cocaine does it by blocking reuptake. So you release your dopamine, you block reuptake, so then it's not brought back into this terminal readily, so there's more dopamine floating out there to do its thing. Amphetamine and methamphetamine do that as well, but they actually also promote release. That's why they're even more of a psychostimulant. Now, having said that, obviously this doesn't just simply happen in this particular part of the brain, right? There's dopamine everywhere you see these pathways. But the idea was that, but it's this particular pathway here that makes you feel good. This pathway here to the prefrontal cortex, for instance, might make you alert and vigilant, not necessarily make you feel good. That's this pathway here from the ventral tegmental to the nucleus accumbens, what we call the corticolimbic circuit. So if feeling good is what underlies addiction, then that's the addiction circuit. Everybody follow? Now, it just so happens this circuit also has receptors for opiates. Right, so you have opiate receptors here at the receiving neuron in the nucleus accumbens. And you also have opiate receptors back here on that dopamine projecting neuron, right here and right here. Those are kappa receptors. So why are those important? So here's the way the circuit was thought to work. Normally, when this circuit becomes active, you get an increase in cyclic AMP, CREB, and the resulting effect is an increase in dynorphin. And what happens with that dynorphin that's being produced? It gets shuttled down the axon to the terminals, and those terminals are feeding back onto those dopamine neurons. So what this is a very classic, typical negative feedback circuit. The predominant neurotransmitter is GABA. These are GABA neurons. But they co-release dynorphin. So the more and more this neuron here, this GABA neuron, gets activated by the dopamine or opiates, the more dynorphin it's going to produce. And so that net effect is a stronger and stronger and stronger negative feedback. So the theory was that that reduction in a state that's caused by increasing B process, going back to the old theory, was due to something like increased inhibition. Therefore, this dopamine neuron isn't activated as much each time. Everybody follow? Right? So if you keep strengthening that negative feedback, it's going to be harder and harder and harder for this neuron to fire, because it's going to be getting this constant inhibition. So again, if this circuit, quote unquote, makes you feel good, and that dopamine neuron can't fire, you're not going to be feeling very good. And so what do you do to try to counteract it? More. Take more. And try to override it. Except, according to this theory, by simply taking more and overriding it, what are you doing? You're just going to keep strengthening this negative feedback. Okay? And so the idea was, you need dopamine to feel good, and all this negative feedback is getting strengthened and strengthened and strengthened as you keep hitting that synapse with drugs, to the point where this neuron ain't going to be firing much, especially under normal circumstances, right? So B process is stronger, B state is stronger. Person feels like crap. Now, very nice theory, very prominent theory for quite a while. But the problem is that it really doesn't explain everything that happens with addiction. In that addiction isn't simply feeling good and not feeling good, or feeling good and having trouble getting back to feeling good. Based on this theory, this is the old thing about the first time you ever take a drug is the most effect it'll ever have on you. Because everything after that point, that B process is strengthened. Right? So that first time the person has heroin, they're never going to get that rush again without taking more, a lot more. Because the body is going to have that B process, this kind of negative feedback occurring. But it's not simply all about hedonics. And so a few years after that, you had a corollary theory come about that tried to describe what has become known as the dark side of addiction. So this was the theory of George Koob that has now become the theory of addiction in terms of neurobiology. And that he said, if you really want to capture what happens, you really have to think of the addiction cycle in terms of not just tolerance and withdrawal, which that old opponent process theory described pretty nicely, but there's other parts that it doesn't describe, such as preoccupation with obtaining more, drive for more and more, and that this causes things like binge intoxication. Or when you start getting over on this side, the idea that a person is not taking a drug to feel good anymore. They're taking a drug not to feel bad. So that the whole thing flips. The person isn't doing it for hedonic value. They're doing it because they feel like crap. And only by taking the drug is it kind of bringing them almost up to where they were normally before. And so George Koob said, we're not capturing that with this model. There's got to be something more. And so he cited research that showed that stress circuits actually become more and more active with drug exposure. And so what probably seems like ages ago when we talked about the HPA axis, remember the HPA axis? Okay. What was at the top of the HPA axis? CRH, right, in the hypothalamus. Well, it just so happens that when you're studying the animals, as you start putting them through these processes of addiction, you see an increase in CRF/CRH in the brain. And not just in the hypothalamus. You see it in other structures, such as the amygdala, which is, of course, involved with emotionality and drive and stress. So, and you see this with a variety of drugs, not just simply like opiates. You see it with things even like nicotine. So what he proposed was a corollary model to that original hedonic model. So what he said was, early on, when a person's just starting to take the drugs, That initial model, which is here, just flipped around. That's the dopamine neuron, that's the nucleus accumbens neuron, there's the feedback. That model is correct because early on, it's positive reinforcement that's driving the behavior. And there's another circuit that's sort of lying dormant. And with time, what happens is actually this circuit, through the processes I discussed, actually becomes essentially dormant. But this other circuit actually becomes more active. And that other circuit involves CRF and norepinephrine and the amygdala. It's all stress circuitry in the brain. So you have that hedonic positive reinforcement pathway replaced by this negative reinforcement driven pathway. Right? Negative reinforcement is doing a behavior to remove some sort of unpleasant or noxious state. So what he says is, yeah, they'll lever press. They're not lever pressing to feel good. They're lever pressing to not feel bad. Big difference. And so, bringing it full circle, when we're talking about things like, well, how do you go about treating people? There's a big difference between thinking it's all about positive reinforcement versus negative reinforcement. And how you would go about it, not just in terms of cognitive behavioral therapy, but also if you're going to do any kind of drug therapy. You would completely attack that circuit differently than this one. Everybody follow? Because we're talking about different neurotransmitters. So I start off with this because I wanted to make you think about how we go about studying these conditions, which arguably are the toughest to try to unlock. This is why psychiatry has moved not a hell of a lot in 50 years. And a lot of it is shaped by how the people are looking at the problem. And then how you go about studying it. If you're kind of looking at it like this, with one point of view, then this is all you think it is. But once someone comes along and says, I'll show you the data, there's more to this, and then demonstrates it, now you go, oh, okay. Well, that changes everything. So you had 50 years of research about one circuit, and now we've been looking at that circuit for about 10. That's why the addiction field didn't move very far for a long time. Any questions about addiction? All right. Okay. Done with addiction. Move on. Anxiety disorders. All right. So with anxiety disorders, I want to present to you an important concept as well. And that is that your psychiatric conditions are largely defined upon by a book. And that book is called the Diagnostic Statistical Manual. It's published by the American Psychiatric Association, DSM. It comes out in a new revision largely every 6 to 15 years, depending. What makes this difficult is when they change definitions on you. And they have done this. So there are conditions that used to be in the book that aren't in there anymore. So for instance, if you go back to DSM-1, homosexuality is in there as a psychiatric condition. That went away after DSM-3. Other things have come in. So if you look at DSM, say 3, which was new when I was in your shoes, and now you look at what we're up to now, the two books are very different. And unfortunately, those books are largely based on things like billing, right? But as scientists who study this stuff, we're beholden to their definitions. So again, you want to know why it's been so hard to do some of this stuff? They keep changing the damn definitions. So if we start with anxiety disorders, here are just some of the major classes of anxiety disorders in that chapter. Actually, it's a couple chapters now. Something like post-traumatic stress disorder actually isn't even in the chapter anymore, which it was for years. It's got its own chapter now. But all these disorders here have one thing in common, and that's a symptom of avoidance. So, and I threw PTSD in here because it does have the avoidance component. So if you just look at a selection of these, so here we have panic disorder, here's OCD, obsessive compulsive disorder, generalized anxiety disorder, then PTSD. Each one of these has their own sort of hallmark symptoms that makes them different than the others. But they all have an avoidance component where the individual exhibits avoidance, either behavioral avoidance, cognitive avoidance, emotional avoidance, usually to reduce the symptoms that are listed here. Okay? So typically what happens is that somebody with a severe anxiety disorder can end up eventually not leaving their house, right? It starts off with avoiding certain situations, like someone with like a generalized anxiety disorder might become terrified if they go to a place with a lot of people, like a mall or something, right? And then eventually, it's not just the mall. They can't even go to the local store anymore because they feel too anxious. And then eventually, they're not even going outside their neighborhood, and it just kind of keeps closing in, closing in, closing in. And so you see that with a lot of these when it becomes really severe. And of course, once it becomes severe, where's the one place they're probably not going? Therapy. So these are difficult conditions to have to cope with. Now, what's going on in the brain? There's been a long discussion about what drives anxiety disorders. Is it quote-unquote fear, or is it quote-unquote anxiety? And if you go to some of the conferences I go to, you can actually get people almost into fights over this. Which I know is ridiculous, but they're science geeks. What else do they go to? So I'll present a couple of the different approaches. First of all, this idea of fear. So when do we recognize that we should fear something? There are two parallel circuits in the brain that will send information to trigger a fear response, which would end up being a sympathetic nervous system fight or flight response. So in the example shown here, we have our two sets of eyes seeing something very fearful, like a rattlesnake. Now, what that's going to trigger is, of course, the neural representation of a squiggly figure through the retina, through the optic nerve, the optic tract, to its first stop at the thalamus, right? Lateral geniculate. From there, two things happen. One, it goes on to what you've typically learned. It goes to the visual cortex to put the image together fully, right? But what was discovered back in the 90s was there was a shortcut. And that shortcut went from that LGN straight to the amygdala. So this information gets to the amygdala seconds before the fully processed information gets to the amygdala. And so when Joe Ledoux kind of discovered these two parallel pathways, he described it as this. Imagine you're walking in the woods and you kind of look down and you think you see something, and all of a sudden you kind of stop. You might feel your heart rate go up slightly, and then you kind of look closer and, oh, it's just a stick. You just experienced the two pathways. That first pathway that got you to stop and got your blood pressure up momentarily, that was what he calls the low road, that shortcut. And it's very rudimentary processed information that's going straight from the thalamus to the amygdala. But it's enough information that it's matching some sort of template there that it triggers a sympathetic response. A moment later, when you now look down and you look at the thing more closely, that other information now comes through what he called the high road, that's more processed, and now you're relieved. And this could be visual input, this could be auditory input. They both have the same parallel pathways. Okay, so the idea of the fear approach is if you wind up having a strong pathway here, a strong low road, and a weak high road, you might be finding yourself stopping and having sympathetic responses, fight or flight responses all the time to things that you need not to, right? And that could be expressed as such as a panic disorder. Now, in the amygdala, there's also learning that's going to occur that can strengthen that association, especially if there's a determination that this has been a good decision and rewarded in some way, or at least reinforced in some way. So getting back to our neuroanatomy, here's the amygdala here, right, at the head of the hippocampus. And there it is in cross-section. The area shown here in green is the central amygdala. That's the major output. That's what's triggering a fight or flight response. These other areas around it, such as the basal amygdala and the lateral amygdala, the medial amygdala down here, they're bringing in the information from other areas, and what they're doing is they're making associations such that you can end up with these learned responses to things, so that anytime the person sees something that looks a little squiggly on the ground, that they're going to immediately have a reaction. And once you learn it, it gets stronger and stronger. Okay? So that's one kind of approach to what might be happening with some anxiety disorders. Now, it turns out that the brain has another structure with many of the same properties as the amygdala. And it's called the bed nucleus of the stria terminalis. So here's the amygdala here. There's the bed nucleus. Its outputs are almost identical to the central amygdala. Not exactly, but pretty darn close. There's a lot of overlap. And so people wondered, why the heck would the brain have two areas that look like they would do pretty much the same thing? And then, as it turns out, this part of the brain does different types of associative learning versus the amygdala. What do I mean? So the amygdala is wired up really well if we're going to do conditioning where there's a stimulus, be it visual or auditory, and then a bad event happens, right? So when we're doing this in the lab, typically we have some sort of tone or light, and then you deliver shock to the floor. They learn that stimulus is bad, so when they hear it again, they freeze. Or if you make them startled, they jump higher. So that's basic fear conditioning. That's largely done through the amygdala, because the amygdala likes very punctate stimuli and responses. So you would have a sound, a tone on for, a few, 5, 10, 20 seconds. Amygdala likes that. That's in its wheelhouse. But what if you have a stimulus on for maybe a minute or longer? A really long stimulus before that noxious event. So its predictive quality isn't quite as straightforward, right? Not as obvious. It's more ambiguous. The bed nucleus actually is where the learning occurs in that type of situation. So longer stimuli, more ambiguous stimuli, for whatever reason, the bed nucleus is where you're going to have that associative learning occur. So when you think about a condition like a generalized anxiety disorder, where it's not all clear what triggers it, right? That's why it's generalized anxiety, versus a panic disorder, which typically you know what triggers a panic disorder. Panic disorder, you could say panic disorder looks like amygdala processing. Generalized anxiety disorder looks more like bed nucleus processing. The more ambiguous that trigger is, the more likely it's probably something like the bed nucleus that's underlying it. So again, if you're thinking about how you would go about treating this, there's a big difference there. Even though both are considered anxiety disorders, even though both of them may lead to avoidance, may lead to overactive sympathetic nervous system, how you get there is through different circuitry. Everybody follow? Okay. So there's one thing to elicit a fear anxiety response. What we really want to do is inhibit it, right? So that it is not occurring and taking over our lives. So this is what, you think of in terms of therapy. So again, over the last dozen or so years, looking at the amygdala and to a lesser extent the bed nucleus as sort of like the focus, if you will, of the cause of the disorder, what would you do to try to calm those brain areas down? And that circuit was found to be in the medial prefrontal cortex. So in the rat, we have two subdivisions of the medial prefrontal cortex that project to, in this case, showing the amygdala. PL is the prelimbic cortex. IL is the infralimbic cortex. Now, as they are shown in green and red, one actually can kind of facilitate processing of those fear responses, and the one in red puts a brake on them. So you can think of it as an accelerator or a brake, or I like to kind of think of it as an amplifier, right? You can turn the amplifier up through the prelimbic or turn it down with the infralimbic. And you're amplifying whatever's happening over here in the amygdala, with that net result being here in the central amygdala, that final common point before you trigger that sympathetic fight or flight response. So what's different about these two areas is simply where they project. The prelimbic projects to those areas where that learning is occurring, that fear-based learning, that bad sound, that bad light, whatever is predicting when something bad happens to me. That prelimbic cortex is thought to be able to amplify that learning. Okay, amplify the neuroplasticity there. Now the infralimbic cortex projects to a completely different group of neurons, and in the rat brain, it's really a very small group of neurons. But they serve a very powerful function. They're inhibitory. These guys up here in the lateral basolateral are excitatory. Excitatory triggering fear, inhibitory dampening fear. And so the thought is that you have some sort of balance occurring between these two areas in the prefrontal cortex normally. And then what may happen with some anxiety disorders is it becomes out of balance. And that presumably this infralimbic becomes weak, if you will. Less influence on this final common path down here. And so people are actively now trying to understand that. Of course, in contrast, it could also be that this prelimbic somehow becomes stronger and just amplifies it. But the idea is they're kind of complementary to each other. So if you turn one up, you're sort of turning the other one down. But the net result here is over here. What's happening over in that central amygdala and that final common path for fight or flight? Are you exciting that circuit or are you inhibiting that circuit? Prelimbic excite, infralimbic inhibit. Everybody understand? Okay. All right. I mentioned before about vulnerability. So, when I was in graduate school in the last century, we learned that stress was bad for your brain, right? I think I mentioned this when we went over the endocrinology stuff. And that if you had high levels of circulating glucocorticoids, right, kind of getting those neurons now to fire again. Oh yeah, glucocorticoids, that was like 2 tests ago. High levels of glucocorticoids were bad for your brain, and it actually caused neurons to degenerate and die. We subsequently know that that was all horse puggy. But again, that theory really fed into how people viewed PTSD. And the reason why was that it was known that soldiers who had PTSD had a smaller hippocampus compared to those soldiers who didn't develop PTSD. And so given that whole theory about stress bad for your brain, glucocorticoids make your neurons die, the idea was, well, it must have been a high level of stress that caused their hippocampus to shrink. And so when you look in the scans and you see a smaller hippocampus, what you're seeing is the result of the combat stress. Right? That's what we were taught. And it was a really prominent theory. Then you had a truly classic game-changing study like this one, where these researchers, who are actually at the VA hospital in Manchester, New Hampshire, were fortunate enough to come across and gather enough twins that served or not in Vietnam. And they did scans on their brains, focusing in on the hippocampus. And lo and behold, found that, yes, some of them with PTSD did have smaller hippocampal volume compared to those in combat without PTSD. But here was the problem, and this was the game changer. There's their twin with no PTSD. It was also smaller. Uh-oh. You want to talk about a paradigm shifter. So it turns out that this clinically described condition was always there. So now it went from stress and high stress in combat making your hippocampus shrivel up to, well, apparently some people have smaller hippocampi and maybe they're more vulnerable to develop PTSD given X, Y, and Z events in their life. Big difference, right? So now all of a sudden, you didn't have people thinking that their brain had shrunk. It was just that it was normal variability and they happened to be smaller. Now, we're still trying to understand what that means. Why does that make them more vulnerable? And there's several theories about that. One of them being tied to the HPA axis, and that the hippocampus is actually one of the structures that projects to the hypothalamus to provide negative feedback. Well, maybe if it's smaller, it's not projecting as much to the hypothalamus. That's one thought, but that hasn't totally borne out. But that's a demonstration of a neuronal vulnerability factor associated with one of these conditions. Finally, there's been more work now in an area of the brain. Remember when I mentioned when we were doing the neuroanatomy and I talked about if you took the temporal lobe and you took the frontal lobe and you went like this, you would look behind it and you would see the insular cortex. People recently have really started looking at, well, what's that insular cortex do? And so studies such as the data shown here have found that people who have experienced trauma, such as intimate partner violence, do show differential activity in this part of the brain. Well, what's this part of the brain do? This part of the brain is a representation of all the internals of the body. So just like you kind of have a homunculus for all your limbs and everything, the idea is the insular cortex has some type of representation for the internal. And so that when you develop some type of anxiety condition or a PTSD, in part that might be driven by exaggerated activity in a part of the brain that's monitoring what's going on inside, so that every little thing is being sensed. Everybody follow that? Imagine how much of a pain in the ass that would be. Every time your heart kind of changes a little bit, like, ugh. So that's the idea of what might be the contribution of the insular cortex. So several different parts of the brain have been implicated in these anxiety, PTSD-like conditions. Of course, pharmacologically, what do you do about it? If someone has an acute anxiety attack, what do you give them? You give them Valium. That hasn't changed in 40 years. You give them Valium. Why do you give them Valium? Well, it increases the effectiveness of GABA, right? You're turning up the inhibition in the brain. Granted, you're turning up inhibition in the entire brain. So, if anybody's ever been on Valium, not for an anxiety attack, I was in a study, that's a whole other story. All I'll say is there's a lot of rules in place now, so things don't happen like happened to me. No one should ever put someone on the subway. I was in a drug study at NYU. So the thing was, okay. All right, quick. All right.
Asking for everyone else.
Okay. I know, everybody's like, what the? Okay. I was in graduate school, I needed money, so. It's $200, I really need a lot of money. I had a friend who was doing her thesis research at NYU, so I agreed, okay, I'll help. Hey, you get $200 out of it. Okay. Okay, you're going to be in, we're going to do baseline conditioning of all sorts of behavioral things and cognitive things, and there was this weird biofeedback thing. And you're going to come back 2 times. One time, you might get a drug. In this case, it would be benzodiazepine. Valium, or it could be something else. And we're not going to tell you because I'm the experimenter, I'm blind to it, you know. Okay, fine. I come back for the next session, they give me the pill, like, okay, and within minutes, like, it's ridiculous. So, you know, I can't do anything on the, and I think I know what I got. And like, no, I'm supposed to be blind to that. Oh, okay. I got to do this thing on the biofeedback where it's like kind of this hula hoop thing. I almost fell over. It was ridiculous. So after the testing, they said, okay, you can go home now. Oh, okay. So I went out, got on the subway. I was living in Astoria. I got on the N train, anybody's familiar with it, and fell asleep and woke up. Thank God at that end of the line, not down in Coney Island. Just completely out. Staggered home, 15 blocks. And then my wife came home and found me completely asleep and couldn't wake me up for hours. And then I explained what I did. So there's all sorts of things in place now where you're not actually allowed to leave, you know, but that was 20 years ago. So that's the little story. By the way, they asked me to come back for another study. I guess since I was just such a great participant. That one was for $970. Not that I remember this vividly or anything. I said, what kind of frickin' drug are you going to give me for that? And they said, scopolamine. I was thinking, wait a minute. We study scopolamine in the lab. That does nasty things to the rats. The hell I'm doing that? So that's where I drew my line. Cost-benefit ratio, you know. Anyway, after that little aside, I should have turned off the microphone. No. Anyway, so what do you do when someone's having an anxiety attack? You give them a benzo. Now, that's sort of a frontline thing. After a while, what people might also wind up doing is taking barbiturates as well to try to calm it, especially if the Valium isn't quite working as readily anymore. And then if you take these other drugs like beta-carbolene or flumazepine, you can actually cause the exact opposite. You can cause a panic attack. So we know that the GABA receptors in terms of pharmacology can diminish or enhance these acute anxiety attacks that can happen in these conditions. But that doesn't mean they're actually treating the underlying condition. Okay, it's sort of the front line response. So the bottom line with anxiety disorders is there's a bunch of different places, and I even get into some of these, that are involved, and a lot of it, these areas are cross-talking with each other, so that's why it's a pretty complicated puzzle that we're still trying to work on. Nonetheless, we are actively working on it, okay? So, anxieties, broad cast of etiologies, several neural systems. I talked about several key aspects that you should remember. We're looking at vulnerability factors. I mentioned the one with the hippocampus and PTSD. And we're still trying to understand some better targeted pharmacology so that we're not simply making people fall asleep like they did to me. All right. Any question about anxiety? No? Anybody feeling anxious yet? No? Okay. Not on me. Okay, moving on. By the way, I'm going to ask again. Anybody giving a presentation tonight? Yes. Okay. That's good because I have to. All right. All right. So I'm going to plow through this. Okay. So major depressive disorder. So there's different subclasses of depression. I'm going to kind of talk about them in generalities and not get into all the specifics. If you want specifics, take the other class. But this is just to kind of give you an idea of the wide range within these categories of that you can be diagnosed with different features of depression. Okay? The key aspects, of course, is that there's depressed mood, some sort of negative affects or states, so what we call dysphoria, and then there's that diminished interest in things that used to make you somewhat happy or pleasant, which we call anhedonia, right? Those are sort of like the foundation symptoms that a person needs to exhibit. And then you have all these other ones that kind of may or may not be there, depending on the particular version, if you will, of the depression the person's experiencing. And notice that these have to be present for a minimum of 2 weeks in order to be part of a diagnosis and causing clear daily distress in their normal lives. Right? So you have to have a minimum of 5 of these. Of course, in the most serious conditions, you're going to have the suicidal ideations or attempts. Person goes in and says they're having suicidal ideations or attempts, I guarantee you they're going to get diagnosed with depression. Some of the difficulties, though, with depression and studying it in terms of the neurology behind it is that some of these features are completely opposite, right? You could have insomnia or hypersomnia. Well, how do you have a model that covers both of those? Weight loss or weight gain? So in general, when we're talking about animal models, we focus mostly on these, right? Honestly, I don't know if any of my animals have excessive guilt or not. They might. I don't know. They won't tell me. I don't think they're suicidal, but then again, they're in my lab, so maybe they are. Now, this is also one that has a very interesting story behind it in terms of the theory that became the dominant theory of the disorder for many, many decades. And it all started with studying something else. There was a drug being developed to treat schizophrenia. It was called reserpine. And it was found that reserpine, in a proportion of the patients it was given to, wasn't really helping that much with the schizophrenia, but worse, it made them clinically depressed. So the people behind those studies said, hey, wait a minute, our drug caused depression. Well, whatever this drug does, that's what causes depression. Hey, it was the 50s. People thought of things very simply. So reserpine set off decades worth of research in what we call the monoamine hypothesis of depression. And the reason why is reserpine causes those vesicles in the terminals of the axons, those vesicles that have monoamines. So that would be what? Dopamine. What else? Norepinephrine, epinephrine, and serotonin. Okay? So reserpine goes in there and busts open those vesicles. Without vesicles, you can't release it. Right? So it winds up floating in the cytoplasm and, of course, gets chewed up by enzymes. So depression must be caused by some type of insufficient monoamine neurotransmission. So what do we need to do? We just need to enhance it. Simple as that. you cure depression. So, in the 50s, you had two types of drugs developed. Tricyclics and monoamine oxidase inhibitors, MAOIs. And I'm sure you've all heard those terms before. Those two classes of drugs are still used today. Okay, we're talking 70 years later. Now, in the meantime, the god known as Pfizer developed this wonderful class of drugs known as the SSRIs. And they bequeathed it upon humanity in the 1980s. And it was found that the SSRIs were pretty effective in some people, not all. And I'll get to that in a second. And then since that time, the development in the drugs really haven't gone much beyond those three basic classes. There's been a little bit of combining. So it's a serotonin reuptake inhibitor with some norepinephrine reuptake properties, that kind of stuff. So you have your Wellbutrins and your Effexors and things like that. But they're based off the same ideas that are now becoming ancient. So what are these different drugs doing? So it's very simple. As I mentioned before, you have your monoamine synapse. And remember, what are the key features of one of these synapses, one of these terminals? You have vesicles holding whichever monoamine. You have enzymes inside that terminal to break down any excess, and then you have reuptake mechanisms to suck it back in after it's been released. Right? Reserpine breaks those vesicles. What does an MAO inhibitor do? It inhibits the enzyme that breaks them down. That enzyme is both inside the terminal as well as outside the terminal. So those monoamines inside that might get broken down because of excess aren't going to get broken down. And those that are released into the synapse aren't going to get broken down as readily by any monoamine oxidase out there. So what's the net effect? More, right? You're moving this one mechanism that's supposed to kind of keep it in check and break the stuff down. You inhibit it, you're going to have more acting longer. So that's the one way you can compensate and get those monoamines more active. The other way is to block reuptake, such that whenever you have, even if you think the person has low levels of one of these monoamines, at least when it gets released, it's going to be able to do more actions because you're blocking reuptake, and it's not going to get sucked in as readily. That's how a tricyclic works. It blocks reuptake. Now, the difference between a tricyclic and a serotonin-specific reuptake inhibitor is simply that. A tricyclic affects all monoamines. And depending on which particular one it is, it's a little more of this one versus that one. Obviously, the serotonin ones are more designed for serotonin specifically. So the nice thing about if an SSRI works for somebody is that they'll likely have less side effects. Why? A side effect is simply the action of a drug that you don't want, right? You have a drug, you want it to do process A, but the drug doesn't know that that's all you want. It does whatever else it's going to do in the body. Those are called side effects. So if your true imbalance is only about serotonin, an SSRI might work really well with minimal side effects. If you're that same person but you're taking an MAO inhibitor, well, that's going to affect dopamine and norepinephrine as well as serotonin. The result, more side effects. The person might be less depressed, but they're going to have more side effects. And some of those side effects aren't great. Now, what happens if that's not the drug that works? So here's the problem with psychiatry. I think I mentioned this before. How do you know what drug to put somebody on? What's the process?
Trial and error.
Trial and error. Simply that. There's no blood test. It's trial and error. So what a psychiatrist will do, or GPs give us stuff out now, is they're going to say, well, I've had good luck with this kind. Let's try it. Come back in a month or two and let me know how it worked out. If you come back and say, oh my God, you made me worse, okay, we won't do that one anymore. Let's try something different. That's psychiatry. It's gotten better, but I'm telling you, trust me, that's what happens. So for somebody who's searching for trying to figure out what that right medication is, it could take quite a while. And so what will often happen is some practitioners will start off with these very specific ones like SSRI, kind of hoping it works. Because if it works, that's great, and the person won't have many side effects. If it doesn't, then they kind of back off and they'll go to something like a tricyclic, which again, okay, it's going to affect more things, but maybe I'll hit it. Yes, they'll have more side effects, but maybe I'll hit it, whatever that hit is, that mechanism. Okay? That's how you treat depression, pharmacologically.
Is suicidal tendencies mainly a side effect, or is it because of the lack?
Good question. So one of the knocks on the SSRIs is if there's nothing to do with serotonin and you take an SSRI, for some people it may make them suicidal when they weren't before. That's one of the dangers. The other thing we know is if somebody is suicidal, when is the period you should be most concerned about them?
When they first start the drug, the first 2 weeks.
Once they start feeling better. Because typically, when somebody's very depressed, they're too depressed to actually go through with it. You put them on a drug and they start feeling better, they might be feeling better enough to actually carry something out. Right? So often it's somebody who is early in treatment or somebody who has been in treatment, and they're the ones that commit suicide. Now, importantly, we should recall that these three different monoamine systems, they do affect each other. So this idea that, oh, if I give a Prozac, all I'm doing is affecting serotonin, it's kind of ridiculous. Yes, pharmacologically you might be only affecting serotonin directly, but to think that you wouldn't be affecting norepinephrine or dopamine downstream is, ridiculous. Of course you are, because they crosstalk with each other. So this idea of finding that magic bullet of what's wrong with somebody who has depression is really not that simple. And I think people have really finally come around to that. Now, the other thing that's always been a mystery for the treatment of depression is, why does it take 2 to 3 weeks for a drug to start making someone feel better? Even if you put somebody on a drug that is effective, they're not going to feel good the next day after taking the drug. Now, here's where the animal models and people are completely dissociated. Most of the research on the animals, you give them the drug and whatever dependent measure they're using as depression, you counteract it with that drug, with that 1 or 2 doses. You don't have to dose them for 2 to 3 weeks for them to stop showing their despair or whatever. But people do. So what's that disconnect? Number one, that tells you the animal models suck. And they aren't telling you about what's really going on. So I put this figure together as kind of a really simplified version of what seems to be occurring and why it takes a while. All those drugs are about the synapse, right? Reuptake and enzyme inhibition, right? That's all happening at the synapse. It's all immediate. So it has to be something downstream that would take 2 weeks in order to make somebody feel better. So the idea is that prior to treatment, you have some level of monoamine release here, and here are receptors receiving that signal, and then you have whatever that downstream signaling pathway is. Here I'm saying it's cyclic AMP, it could be protein kinase C, whatever. Now with acute treatment, let's say this was serotonin and we're giving Prozac. So you're blocking serotonin reuptake. What do you end up with? Well, you have more serotonin floating around the synapse. That acute effect does not make someone feel better. Now, what it's going to do is it's going to have a downstream effect. That downstream effect is whatever these receptors are tied to, say cyclic AMP or any other kind of second messenger system, those are going to be ramped up because you're hitting this synapse really hard now. And with chronic treatment, which is the same acute effect at the synapse, still just blocking that same reuptake mechanism, what has happened to the postsynaptic cell? It has actually reduced the number of receiving receptors of that signal, and yet it has sort of recalibrated such that those lesser number receptors are actually working better at that downstream effect than originally. This would take a couple weeks. So that's sort of a simplified model for potentially why it takes that extra time beyond the acute pharmacological effect of the drug, which is immediate. Everybody get that? different parts of the brain, of course, have been implicated in major depressive disorder. I'm just going to skip over this real quick. You can look at it. One of the things that has been discussed a lot is the idea of the HPA axis is dysregulated. So not everyone, but typically people who have a pretty severe depressive disorder, if you look at their circulating cortisol levels, they're elevated. And so there's been this long-standing theory that, well, somehow the HPA axis is overactive so that you have cortisol spilling out more so than it should be. And so that's going to contribute to whatever imbalance is occurring in the brain, with whether it's monoamines or something else. Simply treating this part of it alone has not yet yielded good results, although people are still trying to see if you can kind of tweak this and get it back in line without touching anything else. Can you make the symptoms of depression lessened? We do know that successful treatment with your traditional antidepressants can also lead to the HPA axis coming back in line. So we know that one can cause the other. What we don't know is whether that's purely a downstream effect or that is somehow causing the other imbalances. But for people with severe depression, typically you do see elevated cortisol levels. You also will see elevated thyroid levels too. One of the areas that has really gained popularity in the last 10 years as one of the other alternatives, if you will, to the delay in effect of an antidepressant is that maybe what it needs is a change in growth factor release in different parts of the brain. And that's that downstream effect. So one that has been studied a lot recently is brain-derived neurotrophic factor, BDNF. And that BDNF is found all throughout the brain. But on that slide with the neuroanatomy, all those areas, people are looking at how BDNF might be contributing. Now, does it mean that BDNF is necessarily low? Not necessarily. But maybe enhancing it might override whatever that underlying problem is. Right? So you can see a lot of these treatments, and you can look at all the specifics with this later. A lot of this is simply kind of trial and error. And that we're really not that close to what's underlying all this. But we are figuring out every way possible to try to override it. Okay? I'm going to quickly move on. Oh boy, okay. I'm going to really fly through this one because I want to get to schizophrenia. And I have to be out of here by 7:15 or I'm going to miss my train. And I know you guys have to do a presentation. So bipolar disorder. Imagine you're on depression, you're depressed, but some days all of a sudden you're manic. Right? That's bipolar disorder, manic depression. Okay? Reason why I got into psychology was one of my best friends in high school was bipolar. And it's a horrible condition. Typically the people that have it are usually pretty bright people for whatever reason. I don't know why. But the mania can be relentless. It can be addictive for some people because the idea of having this elevated mood, high arousal, and you can do anything it's very addictive. The problem is it doesn't last, and it swings down the depression road, and it can have devastating effects. So my friend had been hospitalized no less than 20 times before he hit age 20. And it hit him when he was 15. So he's usually hospitalized at least twice a year for a month. So this can be really rough. So you guys can look at Yvonne later.
Does it happen more in the manic or in the depressive state?
What?
The hospitalization.
Typically it's a depressive state because they fall apart. A lot of them love the manic phase. Now, it can get out of control, don't get me wrong, especially for those where it becomes aggressive and violent. But if you're just one that just loves the idea of not sleeping, it's great. So I'm not talking like I'm not bipolar, but I've met a few in my days. I knew somebody, there was a woman I met in one of the hospitals I worked in. She was collecting master's degrees. And she could do it because she was trying to time out her semesters when she thought she would be manic. And if she could make it, then she would take something ridiculous like 22 credits of graduate courses, right? And try to get it done. So she finished a degree, and she was taking all these degrees at Penn. And the problem was if you don't make it to the end. So as much as she was successful at it, my friend took 8 years to get through community college because he couldn't get through a semester for the same reason. Quickly, the treatment we have still is lithium. Lithium has been the treatment literally for 50, 60 years now. It's still the first line treatment. There has not been anything developed that's any better. It is effective in a lot of the people, and what it's thought to do is help combat these kind of divergent poles, if you will, of neural processing that are sort of clashing, where you have these areas down here that may become overexcited, and these ones up here in the cortex, which are involved in things like inhibition, that are being overridden. So somebody who's bipolar typically has horrible inhibition, right? And that's why they get in a lot of trouble. So as I mentioned, lithium is still the first line treatment. The idea behind lithium is it dampens protein kinase C signaling, and by doing so, it does seem to taper off the manic phases and kind of evens them out, if you will. So instead of having highs and lows like this, it's highs and lows like this. It doesn't cure it. It just makes it more manageable. And a lot of it probably is because if you're not going up that high on the manic phase, at least the difference to your depressive phase is so drastic, right? So that's where it's thought that it's effective a lot on more the manic side of it. It does, though, affect some of these neurotrophic factors like BDNF, so that could also maybe help with that on the depressive side, too. All right. I'm just going to, you guys can look at this stuff later. Okay, I want to quick hit schizophrenia. By the way, if you want to see schizophrenia, do the link. It's like an old non-PC movie of interviews. Little disturbing, so I warned you. Don't come after me and say, he told us to hit the link and I found it disturbing. If you think you'll find it disturbing, don't touch the link. But it shows you different features of schizophrenia really well because they're real people. So schizophrenia. literally means split brain, but it's not multiple personality split brain. What it really is a set of symptoms that fall in two classes, really. Positive symptoms and negative symptoms. The negative symptoms of schizophrenia are somewhat analogous to depression because a lot of it is sort of the anhedonia, poor hygiene, things like that you will see in somebody with severe depression, as well as things like apathy. The positive symptoms are, though, what is going to make someone diagnose the person as being schizophrenic and not something else. And that's the delusions and the hallucinations, right? The hallmark symptoms of schizophrenia. The hallucinations, of course, are the perceptions of things that aren't out there. Typically, they're auditory, but they can be visual. And the delusions, where, you know, the person thinks they're Napoleon or whatever. Usually it's not that drastic, but the person may, though, think they're overly important. And so what do they become? Paranoid. And they think people are out to get them because they are somehow important. So it's not uncommon for someone to say the CIA's after me. Why is the CIA after me? Because they think I know stuff. Okay. And so they can end up displaying some bizarre behaviors. Okay. Take the other class and I'll get into some of the stories I have on that, like the guy who was laying on the floor one day trying to get better reception from Mars or something. True story. What's going on in the schizophrenic brain? Well, here's a good example right here. Look at those two brains, right? One is clearly different than the other, right? If you have enlarged sulci and enlarged ventricles, that's a schizophrenic brain. Okay? They actually have less volume, less gray matter, right? So they show different levels of activity. There's a few kind of key areas that people have honed in on because of these differences in volume. One of them being the prefrontal cortex here. Especially areas such as like right in here, that area 46, area 9 right in here, which is highly involved in attention, working memory, things like that. The thalamus as well, especially the more anterior portions of the thalamus, which are connected to the prefrontal cortex. Those areas are also found to have reduced volume in people with schizophrenia. And of course the medial temporal lobe. So that would include the amygdala and the hippocampus. Okay, so all these areas are interconnected. The idea behind schizophrenia and what could cause such a devastating condition is likely that there are some sort of prenatal events that occur. Obviously, there could also be some predisposition if there's, you know, someone back generations has had it, so there might be a genetic predisposition, of course, as well. But the idea is typically that it's an additive effect of several things. Genetic predisposition, some type of prenatal or postnatal event. Later on, some sort of trigger that occurs, and then it becomes full-blown. You won't see too many kids diagnosed with schizophrenia. Part of that may simply be because it's hard to know if the kid is seeing things because what are they doing? They're constantly doing imaginative play and things, right? You know, look at any kid playing. You might say, okay, now, could that person be schizophrenic? Well, maybe. I mean, look at the games they're playing. So it's hard to diagnose. And again, years and years and years ago, we were actually taught that autistic kids became schizophrenic. Okay? We now know that's completely false. They're completely different. Although they do share some of the same potential etiologies behind them, especially prenatal stressor kind of things. So a lot of the animal models for autism look an awful lot like the animal models for schizophrenia. Yeah.
So the brain difference, is it as you get older that happens? The ventricles are bigger, is it like newborn?
Good question. It definitely becomes more and more obvious. Typically, though, the thing is, you're not going to get a scan on somebody until they're exhibiting. So it's like chicken or the egg, right?
I was wondering if it's like an aging diagnosis that's aging, or you can get it in your development.
Well, that's sort of the $50,000 question is, does it take time? Remember, so the brain is still wiring up, until you're, 10, 12 years old, right? And then it's mostly myelination from that point on. So some of these areas, that wiring's still occurring. And maybe it doesn't occur. Now, at the same time, you saw, the neuroanatomy is pretty drastic. So it may say something about the brain that you're not seeing it that young, despite the fact their brains are quite different. So it may simply be that, the brain is somewhat, plastic enough that it can handle it for a while, and then eventually you wind up having these bizarre things come out. But again, it's hard to tell whether a kid is schizophrenic or not, unless they're showing really bizarre behaviors. And they probably label the kid these days as ADD instead. So there's clearly there can be a strong genetic component to this. Let me just move on. One of the developmental hypotheses is the viral hypothesis that something triggers the immune system at a very young age, meaning in the womb, and that that's where it starts affecting neural development. And it just goes from there. And this is based on an observation many, many, many years ago that a lot of schizophrenics tend to be born in the springtime and early summer. And that second trimester is in the wintertime when you tend to have, be exposed to, the flu, right? Viruses like that. So that's what kind of bore out this whole viral hypothesis, was simply looking at, well, they tend to, be born in certain times of the year. So a lot of the animal models are based off that. If you look at a cross-section slice of the schizophrenic brain, here would be a normal kind of cortex with 6 nice layers of cortex, right? A schizophrenic brain, for instance, say the pyramidal cells that should be in layer 5 here might be in layer 4. The granule cells in layer 2 might be in layer 5. They're actually not in the right place. So that tracking to get to the right place in early development is off. And they don't end up at right places. Again, the fact that they're actually not more bizarre speaks a lot to the plasticity of the brain, given some of these severe things. Okay, so I mentioned earlier that one of the early treatments that was tried for schizophrenia was reserpine. The reason why reserpine was tried was that it was believed that there was actually too much dopamine in the schizophrenic brain being released. So you give them reserpine so that the dopamine stuff would get broken up inside the terminals, and so you reduce the levels. And then you make them depressed. We've got much better with specificity of what this dopamine hypothesis is, and it's actually much more complicated, and that there are 2 primary circuits people focus upon as major causes of the schizophrenic symptoms. And they're both coming from that ventral tegmental area again, as I talked about with the addiction. One of them is a pathway to the nucleus accumbens, which I talked about before, and the other one was the cortical pathway up to prefrontal cortex. Bottom line is that This pathway to the prefrontal cortex is thought to be hypoactive, in that dopamine's influence on this area of the brain is reduced compared to normal. Meanwhile, down here in the ventral striatum, the nucleus accumbens, it's actually elevated. So you have one circuit that's having an elevated net effect, another circuit that's having a net lower effect. And what's thought, how do you have these two things happening, is that if you have receptors here in the prefrontal cortex that aren't expressed to the degree they're supposed to be, they're lower in number. Maybe they're lower in number because they're simply the volume's lower. Regardless of the amount of dopamine that's being released, it's not being received to the right degree because there aren't the receptors there. Okay? Everybody follow that? So you can just be spilling out dopamine. If you only have so many receptors, that's it. So what does that do? Well, getting back to that idea of negative feedback that we talked about with addiction, these circuits have negative feedback as well. So the negative feedback to the VTA would be, I'm not receiving the signal, right? Lack of negative feedback because it's not receiving it. So it turns it up more, but it's not receiving it. Everybody follow? Okay. What does that do to the other circuit where there are ample receptors? It's getting turned on and on and on because this one's working fine. And so this negative feedback loop, because of the low receptors here, is actually making this one become hyperactive. And so these two features lead to different symptoms. Up here you have reduced working memory, reduced attention, things like that. Over here, the combination of the two lead to very specific behavioral abnormalities. One of them is sensory gating. So, for instance, if you were to jump from being startled, right? That was the startle response you just experienced, okay? Now, if I had a tone milliseconds before that, about 80 milliseconds before that, to come on, and then I did that, you would not flinch as hard. That's called pre-pulse inhibition. That's normal. The idea is that there's a stimulus in that sensory gate already, so that when that other one comes behind it, it doesn't have the same amount of effect because it's still processing that first one. That's why you don't flinch as much. Okay? Try that one at home. In schizophrenia, that's not as apparent, which suggests that sensory gate is wide open. And maybe it can just process that much more. That's still under discussion, but it's clearly wide open. The nice thing is, that's something we can study in animals. It's like the only thing. There's another one. Take the other class if you want to find it. But that's the main one that people have studied for years. Is because you can actually look at it in people and animals. I can make an animal startle. I can inhibit that startle by putting a tone in the box. Okay, now let's see if I can make it go away and make a schizophrenic rat or mouse. And then what can I do to reverse it? There's your animal models for schizophrenia for the last 40 years. Is that model. Some would argue that field hasn't moved that far, but that's part of the problem. We don't know when rats and mice are hallucinating or being delusional. Okay. All right. So, we'll wrap up now. Bring your thing up now. So I don't miss my train.